head palliative care consultation team at South Texas VA. She has practiced as a gerontological clinical nurse specialist in St. Louis and San Antonio, and teaches both undergraduate and graduate nursing classes. She's also very actively involved in the Alzheimer's Association, and her research interests include holistic assessment and management of chronic pain in the older adult. And if she does her job well, this presentation will not be a pain.
Well, good afternoon, everybody. I don't know if I should sing lullaby and just let you snooze for now. I hear that it was a really good lunch. I was telling somebody in the bathroom, my lunches the last couple of weeks have been walking our new puppy, Otto, and saying, "Good poop, Otto, good poop." But I hear it was a good lunch, and I feel real fortunate to be here today and talk about this issue. So we'll just get into it, and hopefully, you know, the way I like to work is, and I'm sure you do, is to really listen. So hopefully in the next hour, not only to keep you awake, but so that I can learn, I would like to hear your experiences in dealing with end-of-life issues, because I'm sure all of you have either had it in a personal venue with family members or in the professional venue. And I think a huge part of learning is sharing that. And I think we're really fortunate to have the mix of the medical and legal in which to share those issues. So let's go ahead and begin. Today we're just going to, first off, I'm just going to clarify some terms in pain that come up a lot when we deal with this. There's a lot of fear, a lot of anxiety that sometimes comes up. And then we'll talk about some specific issues of the older adult at end of life. And in the earlier ethical talk, those issues came up in one of your slides perfectly, and I just smiled. So you're probably going to be hearing some stuff reinforced today. And then discern what are the barriers for our comfort care interventions that we do. Because in this day and age, pain still is a huge issue. And it's been around as long as dirt, I think. And we still are discovering things about it, and we're still having difficulty managing it. And we'll discuss some of the reasons why and some of the opportunities that we have in research and in practice to hopefully keep moving forward in the comfort arena. And then last is talk about overall strategies. And when I put this together, I decided to really look at comfort rather than just pain, because to me, I think my aim when I die is that I would like to be comfortable. And being out of pain is defined differently for different people. You know, so you may have great psychological pain, not a lot of physical pain, but really the suffering. So I want to look at pain holistically. Is everybody good with that? Okay. So I just want to kind of review a couple of things. Acute pain, cancer pain, and chronic non-malignant pain are typically the ways we look at pain. Acute, has anybody here ever had acute pain? Can I see a show of hands? Yes, good, okay. So we all know, you have that for a reason. God, when He put our bodies together, He did a great job. And acute pain serves a purpose. It alarms us, it triggers us, it tells us to get the hand off the stove, you know, or that apple dumpling sauce doesn't feel good on the thigh, you know, when it's boiling hot. So it's a protective mechanism that we're thankful we have. It's typically really short in duration and usually somatic or visceral. So it's either, you know, like a broken leg, pressure from an ulcer. I mean, there's a reason for it. Now, when you get into cancer pain, cancer is such an enigma in so many ways, and so is cancer pain. We've come a long way, but since it is such a distinct entity, it gets its own domain. And in cancer pain, when we talk about it, we always specify where. Because if somebody has pancreatic cancer, if somebody has bone cancer, if somebody has cancer of the brain, they manifest their pain differently. So in our literature, in our treatment plans, and in our research, we address that specifically. So that's why that's listed as such. And then is chronic non-malignant pain. So it's pain that's not going to kill us, but it's pain. Can anybody give me an example of chronic non-malignant pain? Arthritis. How many in this room have suffered at one time from chronic non-malignant pain? Okay, there's a pretty good show of hands. And isn't it frustrating because typically you're going to have to learn to live with it. It doesn't have a purpose. You know what's going on and it's not serving you well. But it's just lingering and it's dragging you down. So the treatment strategies are a little bit different for that than for acute pain. Okay. Pain definitions I want to go over with because these set off alarms with our clients, with our healthcare industry, and sometimes with our legal industry as well. And so I wanted to just clarify what these are. So if it's a review, this is your nap time, the fellows in the back, okay? Because I'm sure you guys have heard this many times. Physical dependence is when you develop your body, you take the medication, everything's going well, and then when it's withdrawn, you feel it. It would be like if you had, like my love is, besides my husband, is chocolate. And so if I had chocolate every day, and he came home and he always gave me a chocolate bar, I would get used to it. And then if he came home and didn't give me a chocolate bar, I would miss that a little. That would be my analogy with it. I've gotten used to always having my chocolate bar. And now it's gone, so I notice that it's gone, okay? It's typically not a big problem. It does develop after opioid therapy. It also develops with some antidepressants when you take them, and then you withdraw them. People can feel a difference with them. So it's good to let the people know what that is, so it decreases the fear. Okay, and you can also taper, and that helps. But the reason for that is just that your body has gotten used to this in the system, and then when you take it out, it notices something's gone. Now, tolerance is a little bit different. Tolerance is defined as a change in the dose response. So you're taking the medicine, and it's working, but your body acclimates to it. So it gets used to it. So to get the therapeutic dose, you need a little higher level. And this is another thing that really needs to be explained to our health professionals, because not everybody really thinks about this, and they're worried about hooking the patient on a drug for a long time that they don't need to be on. And it really alarms family members, because so if you explain what it is and how it's a physiologic response, that no, mom isn't going to be on a high-speed chase trying to get more drugs or something, you know, but that this is a normal physiologic process. And then the third term is addiction. Now here you may get mom into a high-speed chase if she gets hooked on this. But look at, what I want to really point out is that 0.1% of the population has an issue with this. And the important thing with addiction is that it's not just physiologic. It's physiologic and psychological. And it's self-harm. It's when you're hurting yourself to achieve something or hurting others to achieve continued use of a substance. Now, in the VA population where I've done the fellowship, it is very important to know these terms when we're dealing with pain management, because we're dealing with a population that statistically in the nation has a higher percentage of substance abuse clients. So we have to be sensitive. Does it mean that we don't treat their pain? Absolutely not. It means we treat their pain, but we have to become more artisans in how we treat that pain. We have to acknowledge it, we have to taper and titrate it, so that the patient is well managed, but well managed for life. Does that make sense to everybody? Okay. So those are some of the pain terms. Okay. I wanted to talk about pain management at end of life, specific to where we are dying statistically in the United States. I think it's important. How many in this room want to die in a hospital bed with an IV and a couple of tubes, and a roommate that you've never met. How many? I'll tell you, I don't see any hands going up. But look at this, 50% of our individuals in the United States are dying in hospitals, and I think that's important. 25% are at home. We would love to push more of that happening, but right now with the statistics and the trends, it's not happening. Right now we are still putting a lot of time, energy, and at end of life in the institutions. Specific to the geriatric population, and this speaks to your slide that you talked earlier in ethics, or what are some of the issues that really complicate and give us great opportunities to be challenged and to care. The geriatric client at end of life, often with cognitive difficulties. We've got multiple chronic illnesses. Advanced directives are a huge issue. Pharmacological dynamics. I want to just review, because we always talk about how when you get older, you have to be more careful with the medications. And has anybody seen a patient come in like on maybe 14 different medications? I see a nod. Yeah. And do the patients know what they're taking and why they're taking them? No. Okay. So I want to talk a little bit about the pharmacological implications as we age, especially at end of life. Caregiver burden. Has anybody ever taken care of an individual at end of life personally? Can I see a show of hands? Has it changed you as a practitioner? I hope so. It's sacred time, and it's a very vulnerable time in the West. So I want to speak to that. And then last, just the progressive loss of function. And what goes along with that, because at the end of life, you're leaving behind things. And typically, that's a lot to metabolize as you begin to lose function or lose certain things. I think earlier the vignette was, we had a vignette about losing the car and making it safe for the person, and that's difficult. So with multiple chronic illnesses, how to deal with those at end of life. Typically, does anybody know how many chronic illnesses a geriatric individual typically has? Anybody? I hear laughter.
2.5.
Very good, 2.7. I'm impressed. He's off by a foot too. Okay. So typically, over 55, we've got 2.5, 2.7. We'll give you that. And diseases going on. Okay. Now, as we age, typically that increases. So by the time we're 80, we've got typically 4 chronic diseases coming. Okay. And each of those therapies, and actually the disease process itself, affects the whole body, right? We have compromised systems as we age. Our systems maybe aren't as fast, or we know that our blood flow is decreased a little. We know that our renal system is diminished in size and function. We know that we absorb things slower. So our homeostasis, when we change slower and it takes longer. How many in the room can already tell that at the age of 30? Hence the cheaters, I mean, we're there, so just to amp that up exponentially as we age. So we're dealing with, at the best, even our healthiest, when they get compromised, they're sick, they go into the hospital, they're going into a different environment, they're going into absolutely different routines, they're being challenged, they're out of their norms, and they're in this fragile state. So we're seeing the worst we're seeing them in their worst situation with few resources. And we really need to be cognizant of that. And the theme of this day is the cognitive function and the impact on that. And how do you think chronic illnesses affect our cognitive function? When you guys just have a headache, do you think, well, no, After you've had lunch and it was really good and you're in a warm room, are you thinking real well? Yeah. So the deal is that with the chronic illnesses, it ups your odds for cognitive decline, at best. In fact, they did Solano and his colleagues did a really nice meta-analysis review of articles. And they looked at the incidence of confusion, cognitive changes, through multiple studies. And look at the prevalence that we have with confusion. And this is just looking at one disease. So like with cancer, there is a variance, and they sampled 9,000, there were 9,000, over 9,000 individuals in 19 studies examined. And the prevalence of confusion in individuals with cancer varied from the studies from 9% to 93%. That's huge. Then you look at the AIDS, we don't have the N on that, so I don't know how many, but 2 studies show that the percentage of cognitive decline and confusion to the point of confusion was 30% to 65%. So typically at least half the people you're seeing are going to have some cognitive impairment. Heart disease similar to COPD. Now put these together and the comorbidity for that confusion element substantially increases. Does that make sense to everybody? The next topic that I think is sensitive to the older adult at end of life is the issue of advanced directives. How many people in this room have advanced directives? You guys are doing good. That's good. I would say about half of us. And the other half, do you deal with individuals that should have advanced directives? So, and we still don't have them. Recently, I was talking with an attending in his group, and we were talking about it, and they were working on an oncology floor. And I said, how many of you guys have advanced directives? None of them did. And the attending laughed. He goes, yeah, my kids are asking me about that. So it's a huge issue, and it's a huge issue when we're talking about capacity. It's a huge issue when we're talking about competence. And it should be done between the physician and patient. But how many people really want to sit and talk about doing advanced directives when they're feeling good? Is that something that comes up at the end of the golf game? You know, hey, yeah, I just got those advanced directives. I really don't want this too good. I mean, you just don't talk about that. And it's huge. And the research is found that really the most important thing, you know, people have advanced directives. How many people have seen advanced directives in place and then at the 9th hour they're changed? Okay, so yeah, bingo, that hand shot up, you know, because it is more common than not. So the important thing with advanced directives is what? Do you think?
Conversational things.
Bingo, the conversation, to talk about it. Because the earlier speaker, Ms. Whitehead, I loved her vignette when she talked about the jury room and how they brought in the you know, we no longer bring in the patient on the stretcher. We don't need that. But in a similar way, when we're talking with the family at the end of life and the patient isn't able to be in the room for that conversation, we need to bring him in, don't we? And we need for the family members to be the ones to bring that up. And we do that through our listening, in asking the right questions in a sensitive way to cover a very difficult topic, so that ethically we can make the most comfortable decision for our loved ones at the end of life. So what we do in the healthcare arena is we bring that patient in. We ask the family members, I don't know your father as well as you do. Can you tell me a little bit about him? That gets them into the mindset of their father's patterns, his values, what he likes, what he lived for, and those are the values that shape what we want to do in advanced directives. And those conversations are the most important piece. The communication is the essential piece. And and the sacred, acknowledging the sacredness of that conversation you're having with either the individual or the individual's family, or optimally both. And I cannot say that strongly enough. I know sometimes we rush in and in 20 minutes we want to get an advanced directive or a DNR. And that you have to really sit and look where that patient is, where that family is. And they don't have the same timetable we do. They can't emotionally, psychologically. But yes, we have to get certain things done. And so it is really an art on how we communicate, how we empathize, and how we really respect our core values, their core values, and really what is best for the patient. And I think that goes a long way in these discussions, coming out optimally. Does that make sense to everyone? Has anybody not seen this slide? We talk about cure versus care. And the conversations for the advanced directives often don't come up when we're talking about cure. And in the hospital, do we talk more about cure or care? Cure, yeah. Do we really think people heal in a hospital? No, they want to get home, right? They want to get home to their dog, they want to get home to their garden, their favorite TV show, their favorite tea, and that's where they heal. So the hospital is more curative. And that's an issue with end of life, since the majority of people are not dying at home, they're dying in the hospital, where the focus is on cure. And then that conversation for the advanced directives, for the DNR, that all comes into place when all of a sudden, oops, we're not going to be able to cure this. We're going to flip you to care. And oftentimes it's a flip instead of being a gradual process. Is that wrong? No, I don't think we can put a judgment on it. I think we need to say it is. Because that, we are trained in the healthcare to cure. We are financially reimbursed and kept alive by doing treatments to cure. We make no money by caring. And unfortunately, that piece of revenue, I think, influences our look in institutions on how we're managing pain management and end of life. Because we don't get any big perks or reimbursement. But if we threw in 3 treatments, we do. So almost our society, the way it's set up economically, we're reimbursing, not doing it. And we're really working hard to change that around. But even in long-term care, that's where we're at. We are trying, we have to document we're rehabilitating somebody, right? If you're 98, you've got contractures, and you've got severe dementia, what is the latest stats for people in long-term care with dementia? 72%, I think. Are we really going to rehab them? And is that ethically the right thing to be doing? But we're kind of mandated. So we have to live pragmatically with where we're at. So I think we need to be cognizant of that. And I think the more aware we are, the more honest we are with that, then that allows us to go, aha, and move on in the right direction. And hopefully make policy changes. Pharmacokinetics, I want to just go over briefly and speed. But it's true, we get a little more acidic. And we slow down a little. Our tummies empty a little slower, our blood flow is a little slower or decreased. So we're still absorbing everything, but it takes us a little bit longer. So with some of the medications that we're receiving as we age, we're gonna absorb it, but it's gonna be at a slower rate. On the distribution thing, it's sad but true, as we age, we lose our wonderful mass, our lean body mass, our protein, and we dehydrate a little bit, and we gain in body fat. I don't know, has anybody already noticed that a little bit? I have. Very humbling. So the ramifications with our drugs are that a lot of our drugs are then if we don't have as much protein in our body, what happens if they're protein bound? Anybody? Less absorption, right. Well, no. We have more absorption. There's less binding. So actually it's freer in the body. So it's a higher intensity that we get from that drug because it's not bound by the protein. Does that make sense to everybody?
More bang for your buck.
Pardon?
More bang for your buck.
That's right. And with that bang for the buck, we want to give littler bangs, right? You know, we want to go slow and give a little less and see how they go. But we always have those little mantras, but I want to make sure everybody understands why. And to look at the individual you're caring for and how that makes a difference. Because if you do have an older adult that has an inflammatory disease, has cancer, then they're going to have less free drug in the body because of those diseases. So as a clinician, we have to really know our patient and how they react to it. Metabolism gets blamed for a lot of things in life. Age-related changes with the pharmacokinetics really isn't an issue. You know, we metabolize the way we metabolize. It slows down a little, but not statistically significant. The big player with this is how we've been living. So if we've been, you know, out to the tapas bar, smoking, drinking martinis, what else? Eating high-fat appetizers, that's going to play a bigger role. Okay? So when you're looking at your individual that you're taking care of, you need to look at the lifestyle. And that will be an impact. And why? Because what organ is that really affecting? It's affecting your liver. Okay? And that's, you know, your metabolism, a lot of things. Elimination, we already talked a little bit about the kidneys decreasing in size. But the way we're made, it's amazing. We can function very well with very little kidney-wise. But still, there is a little decrease there. And so we have to look at the water-soluble drugs in this one and see how those are being eliminated. And then again, with the serum creatinine not being an accurate measure, because our muscle mass is the source of creatinine and it naturally declines. So what worked as a young adult and a middle adult isn't a good measure as an older adult. So those are the things from the geriatric venue that impact how drugs are used and metabolized and consumed by an aging body. And that's something at end of life we really need to put into play. You know, add that on with the chronic diseases, add that on with the other issues. So as a provider at end of life, you really need to look at the whole picture for the individual. Okay. Another issue is caregiver burden. Now we have a pretty good show of hands of individuals that have cared for somebody or been in a situation at end of life. Has anybody in this room experienced caregiver burden with them? Yeah. Does anybody want to talk to that? Did you readily come in and say, you know, I've got caregiver burden and I need help? No. You know, I think we talked earlier, who was one of the presenters earlier was talking about a family that was held at gunpoint for 24 hours and didn't think there was any problem with mom. That's good caregiver burden in denial. You know, they just don't see it because they're so in it. And that's life, you know. All of a sudden these individuals are doing ADLs, IADLs, giving meds, managing medical equipment they can't even pronounce and didn't know existed a week before, going in between explaining what the patient wants to the physician, explaining to the physician what the patient's complaints have been, and then informing other family members and friends what's going on. That's pretty heavy in and of itself. Then add in the change of role. You know, maybe they're not used to doing the finances. And all of a sudden they have to do that, you know. Issues that weren't a problem are a problem. And they themselves often have chronic health issues themselves. How often do we see spouses carrying this load? More and more. You know, it's not atypical. I think we see that a lot. And typically these individuals are older as well, and so they've typically got some arthritis or they have some high blood pressure or a few other chronic illnesses. Now, and their status is pretty fragile as well. So you add all this on top of it, and we can get into trouble pretty quick. Because if the person caring for the individual goes down, two people are down. As opposed to if the person that is the patient at the time goes down, there's one person down. But everybody laughed a little when, do you acknowledge you have caregiver burden? And do you want to acknowledge that? There's something, I don't know what it is, but we say, we can handle it.
You don't realize it until after you go through it, too.
Right, you're so much into it. That's a very good point. You're in it, so it's almost like defensively, as a coping mechanism, you can't honestly look at it, because if you do, you couldn't deal with it.
And I know I think my situation, my dad was not at home, she was my mother and stuff. And my cousin was his doctor, so, you know, it was like a kind of tight thing. We were going to be supporting each other. You know, after we talked about it, we realized it really did a lot.
And you bring in a whole nother thing with boundaries. You know how tight are those boundaries, how wide are those boundaries with the family dynamics. And you guys had a very tight boundary. Did everybody hear her? She had the physician was family member and the care providers were family members. And it was in the home setting. So typically you can get pretty isolated pretty quick that way and not realize it. Huge. Any other comments on that?
This is one of the things you want to avoid is use the word burden, because most people put a guilt over, you know, I don't want to say it's a burden because I love the person.
Right. There is a value.
Acknowledge a burden is to, you know, there's a guilt association there.
That's a good point. That emotional component with it is huge. And then that concept of guilt is huge. And at this time, all those family issues that have started from, you know, the day you were born seem to come to surface at end of life. You know, you're back to being an 8-year-old. You know, I mean, you see those issues come up within the family dynamics, which is another layer on that.
I don't need to show my friends what is
I'm glad you asked that. It is independence, activities of daily living. So it would be like managing the finances, doing the grocery shopping, maintaining the house, maintaining the yard. And not everybody has the finances to hire that out. And if you're in a home, you're going to have maintenance. And when you're taking care of dad at home, your focus is on that, not on these other things. And so when you have to attend those, you're overwhelmed already, and it extends you out even more.
I was going to say too, finances is really a huge thing because typically one of the wage earners is knocked out of employment or doing an extra job that is doing the retirement for little income.
And that little bit makes a huge difference. And so I'm glad you brought up. That brings in a whole nother burden. And I like how you said, as a practitioner, we don't want to use that term. So, because if you ask somebody, they will not, oh no, it's my pleasure to do it. They've done so much for me. Which, I'm in that arena too. You know, I want to be able to take care of my family. You know? So one of the things I've found helpful, since caregiver burden is an issue, and people are reluctant to bring it up, from a pragmatic point, if you see it in your practice, you can say, what do I do? Because the person's not going to acknowledge it, and you're not going to bring it up as, you know, are you burdened? You know, you're not going to say that. What you can do is this 5-minute inventory. It's called a care, and there are other inventories out there. This one's pretty pragmatic because it takes different aspects, so you can kind of hone in. It helps you discern where the greatest burden is, or where the greatest energy expenditure, might be the better word, energy expenditure is. And it's a multi-dimensional assessment, 24 items, takes 5 minutes to administer, and it measures your time dependence, developmental burden, physical burden, social burden, and emotional burden. And that covers, not everything, but it gives you a pretty good pulse of what is most harmful to the individual. And then, as a practitioner, you can say, these are resources that might be helpful for you. And sometimes doing something like this on paper helps the family see it for what it is and go, wow, I really am doing a lot. Does that seem to make sense to everybody? How this might be a helpful intervention for guiding? Because how many times do we get in a situation where they're just on empty to the point that they need help? You have a question or comment? But offering those resources are huge, and at the right time. You know, just like hospice. When do people go into hospice? How many days before the patient expires typically? You know, less than, 48 hours is the national average now. It's too late to be going into hospice, but you get back to that whole emotional value we put on that. We don't want to talk like we're giving up on the individual. So a lot of it, the take-home message today will be educate, educate, educate. What is the truth out there? And offer the resources. And communicate.
Do you have a flow for that?
Yeah, Novak and Guest, 1989. That's the actual inventory. That's the name of it. And it's by Novak and Guest. And it's a nice pragmatic tool. Right? And you can use it in research as well. Not that you guys want to do that, but just put it out there. The last area that I think is really impacts on the older adult as they near the end of life is their loss of function. And how there's a natural grieving process as you lose things, right? I mean, I'm grieving that I need to use these to read. You know, I just like, I wish I would have appreciated my acuity sooner and younger in life, you know. So if I've noticed that with myself, imagine these huge losses that come on quick. You know, you don't think they're quick, but they are quick. And when people go downhill, they tend to go down, you know, within a 2 to 5 year period, you really see a lot of decline. So, and with that, it's appropriate to grieve that, to acknowledge it, to grieve it. But how many times do sometimes we get callous in our profession that we go, well, what do you expect? Well, it's part of getting older. Well, you know, but is that really therapeutic? Is that really helpful? Is that really acknowledging the dignity of another person and their loss? So we have to be real sensitive to that. The loss of role in family. I think Susan brought up the finances. And I think that's a huge thing. Have you seen that in your practice when the wage earner no longer can perform in that role, or where the nurturer is the one that's dependent and having to receive nurturing? How that actually, giving up that role that they traditionally have had, that's a hard thing to give up. Has anybody seen that? So that's something to be real sensitive to. And then the loss of physical abilities. Okay, and there's multiple other losses that we can talk about, but I'm not going to today. Karnowski's performance scale. How many have seen this, or they talk about this in the hospital? This is one pragmatic, really quick, really kind of very coarse way to talk, but it really brings to the forefront how these losses occur. And to me, in kind of almost like a rough, in-your-face kind of way. But it works, and that's the way we talk in the hospital. But if you really think about how these losses, they're huge. And when you're, you know, it's one thing for another person to go through it, but when you go through it, it's, you know, very different. So to really, that walking in their shoes, to go from being totally able to work, carry on normal activity with minor symptoms, to being severely disabled, dependent, needing special care, needing help to get out of bed and go to the bathroom. You know, it's very difficult. And sometimes you get into, you know, just even the roles and then the status. I was in a family situation where my, and I really don't manage my father-in-law's care. But I get called in when he goes to the ER. And his health care is not what I would manage it differently. But I respect our family dynamics, and I honor that. But at the 9th hour, I always get called into the ER. And this last one, he had to go to the bathroom, but by God, he wasn't going to go on a gurney in the ER. And they took him for a test, and they brought him back, and they didn't have his pants, and it was just the most painful, suffering aspect for my father-in-law was the fact that he didn't have his pants. He had to go home. Everybody else in the family left me with him because I'm the RN. And, or I wasn't fast enough. I don't know. And he did not like that. He had to somehow get his pants and get them on, and I was the only one in the room. And he just looked at me and said, I can't do this. And then when I tried to help him, it upset him because I couldn't do it. You know, so you get into these dependent things that are huge, you know. And I add this on in the end of life when you're really totally incapable. And I do have to tell you, my father-in-law has a bladder beyond belief because he had like 2 liters of fluids. And by God, he did not go to the bathroom until he got but we had to speed home for him. You know, I mean, their roles, what they want, their intimacy, their privacy, those are losses that typically occur at end of life. We cannot appreciate them enough. And they become mundane and rote to us because we deal with it all the time. So, you know, just like the individual said in caring with the family in the hospice setting, what do you do for fun? That fun refreshes them to be more present, to be more whole with their family member at the end of life. For us, what do we do to refresh ourselves so that we're more present for these people at end of life too? I think that's real important, to not lose that sensitivity. We've already looked at this. Just wanted to drive home the point again, though, that at the diagnosis time, we're all into restorative, and we don't talk the palliative. We need to start talking about palliative and quality of life, and put it in the context of the ethical decision-making life. What are our core values? What do we really want out of life? And start thinking about it. It's almost like an ongoing midlife crisis, you know. What do we really want? Who are we really? And to walk that with the people earlier so that they can really have an end of life that's cumulative, not nostalgic, that can look back and say, few regrets, because they've had time to digest more. Does that make sense to everybody? If we do it along the journey rather than the last 2 weeks or 3 months, I think that's more important. So, how do we improve care? How do we improve comfort at end of life? Currently, the statistics show that 90% of the deaths that occur each year are pretty predictable. So that means we're not surprised. We may be surprised at the time or the course, but if somebody has metastatic cancer, we're not surprised at that. If they have congestive heart failure for 20 years and COPD with high blood pressure and went into chronic renal failure, we're not going to be surprised, right? And that's what that's basically saying. Again, the deaths are occurring in settings that aren't equipped for end of life. They're equipped to care, to cure them rather, to get them back out into society. Not to look at end-of-life issues and help the person transition into their next phase. Physicians have difficulty identifying those who are dying. Who's a physician in this room? Can you speak to why this would be an issue? Why would physicians have difficulty identifying people who are dying?
A lot of times, they have seen it obviously in the hospital. They have seen
Another comment?
We are not trained to face death. We are trained to cure people and to take them out of the hospital.
Absolutely.
So it's hard, and sometimes we take it personally. And it depends on our background. People with surgical training, they are more resistant to give up with the patient. And sometimes they overtreat the patient. They resist to believe that the patient is dying.
Well, you bring up so many good points. The overtreatment, our mind frame, the framework that healthcare providers have been trained in the school is for curative. The hospital is a place to get them treated and get them out. And especially the older client, because the longer the older client stays in, it ups their odds of delirium, right? And downward spiral as a result of that. Because people that have delirium in the hospital have a higher incident of what? Of death, you know, and of readmission. So, and then the third point that I really like that you brought up is your personal experiences. And so really, the take-home message is, what do we think? We have to look at our value system. We have to look at why we're doing what we're doing when we're looking at caring for other patients. So we know how much of it is ours and how much of it is theirs that we're bringing into each situation. And that gets back to the ethical decision-making in practicing ethics day to day. And number one, if you're going to do that, and we are making ethical decisions every day in healthcare and in law. Because how often, what is an ethical decision but two things that you value coming into conflict? And then you have to decide what's the priority, you know? So I think really examining your experiences, your background, and your baggage, if you will, facilitates better decisions and being more grounded in our practice and moving forward. So, excellent comments. And we're not trained on how to provide comfort. We're trained on how to do another treatment. Okay. So the approaches to improving care is to identify the dying patients and to implement consistent care interventions. And I think we're getting short on time, so I'm going to buzz through these, so stop me if you need it. Okay, we've already gone over this. Okay. Nursing homes, it's the same thing. It's a culture where we reimburse for treatments and for rehab instead of for end-of-life and quality comfort care. Staffing issues and education and training are huge issues. And I think the staffing issues go into the hospital as well. I don't think that it's just a nursing home. The poorly controlled symptoms at end of life that we've seen, pain over 50%, and look at that ranking of pain. The pain is severe. So these individuals at end of life are still extremely uncomfortable in over 50% of the cases. We have difficulty breathing in over 50% of the cases. Problems with communication can be from a physical or cognitive vantage point. Documentation of the DNR in the last 48 hours. How many people have seen this? And how many do you think are really cognitively intact when that DNR is signed? That's an ethical issue, you know. And it's a pragmatic one. What, you know, you need it. How do you do that? So it's an issue. And 80% of families interviewed felt that there were times when the patient was not treated with respect. But I think you can apply that to American General. If you go to HEB, somebody will complain they weren't treated with respect. So, you know. But I think we need to be cognizant we're taking care of people at the most vulnerable part of their time. So of all the times to practice respect, that would be one. So what are the components we need for best practice? How can we guide our healthcare system? And I think really make the focus of the orders for comfort. Really review and discontinue unneeded interventions. This is probably the biggest thing I did once I got the education and the troubleshooting done as a clinical nurse specialist. You come into a floor and you kind of get them up to speed on what the protocols are, how do you normally handle it. In about 6 months to a year, the staff are comfortable with how to handle the issues, so you're getting called less. So what I found myself doing was going up and looking at the meds, looking at the treatments, and seeing what was needed, what was not needed, what was time consuming. Okay. Review of options for pharmaceutical management so that we combine meds and minimize. And communicate with the family and the patient. What's important, what hasn't been said, and make sure they have the time to say it. On that end, with the communication, what are the most important things to say at the end of that? Was it Ira Bach's book? You need to say, I love you, forgive me, I forgive you, thank you, and goodbye. And those, if you forget everything else, remember those, because that conversation in your life is the most important. And that's where the sorrow comes in, if those things were not said. So that, to me, is critical. And give the family and the patient time to do that. And even if the patient can't hear, there's a knowing there. And to let the family know, I think is essential. Diet and comfort. Family members, there's a cultural component with food, right? And so let them have what they want, if they can handle it. The puddings, the thicker stuffs are better. You rarely need to be NPO. As far as feeding, unfortunately, the statistics, 25% of advanced dementia patients die with tube feeding still being administered. We need to educate, and we need to really send home the message how that we're not feeding the patient, we're feeding the diseases. And how often that food and the fluids produce a pain because of the fluids. It's not natural. It's not natural. And that by increasing the fluids, increasing the food, we're either feeding the tumors, the disease, or we're increasing pressure in the body, which is a visceral type of pain. And when you explain that to the family, I think a lot of times an aha goes off, and we don't want to do that. And then they change their course. I think that's real important. Activity. Who wants to, has anybody been laid up in bed for a full day? Aren't you going nuts by the end of the day? You know, as we die, we don't necessarily need to be in bed or waiting in bed, okay? In fact, heart patients, pulmonary patients are more comfortable out of bed. So positioning, you look at that. Vital signs, problem when 75% of individuals are dying in institutions. Because institutions have what? Policies. They have policies on vital signs. Do we need to be taking vital signs on a dying patient every 4 hours? Or in an intensive care unit every hour? Do we need to be doing that? No. So we need to look at our protocols and act accordingly. And actually those numbers and those beepers and that technology takes away from those 5 things that need to be said at the end of that. They're very distracting. PIC lines are helpful if we do have to give meds. Other than that, IVs and sub-Qs, I don't think are really advocated. Again, we talked about the pressure and how they're really not comfortable. In fact, they can cause more suffering. We've already talked about that. Oxygen therapy is very important. It's the one thing that we really want to keep because it's symbolic of life, you know, the spirit. So we want to keep those intact as long. Use the nasal pumps. Don't use the mask. It's just occlusive. And the 4 meds. These are combination meds. The morphine, I think, is very good. Dexamethasone is very good. Haloperidol, definitely used, but small dose around the clock. All of these, if you do more around the clock, it works better. But lorazepam, this is what the literature says. I'm not a big fan of geriatrics and lorazepam. But if there's a lot of seizures, then that comes into play. So if you see these meds, this is why, and they're used with combination to handle multiple chronic things, and that's typically helpful. And I think the secretions, I think we've talked a little bit about the fluids, sort of the comforting. We've talked, don't do procedures you don't have to. And totally get the whole team in, because end of life is the whole person. So the chaplain has as huge of a role as the physician. And don't underestimate your thoughts and your needs in the situation. And if you as a team member, as a lawyer, as a paralegal, as a social worker, as a nutritionist, if something in your gut is telling you to speak, speak. Okay? So in summary, take them where they're at. Get rid of the judgments. Clean your own house before you judge another. Communicate, I think, is the most essential thing of all. And I think when we communicate the truth to the family members and to the other healthcare providers, it makes the journey at end of life a little bit more comfortable and more humane. And those are the references. Are there any questions? I went a little over on time. Yes? Thank you. Do you have a question or comment?
I have a comment. I'm the director of admissions at a large nursing facility here in San Antonio. And I disagree with your statement that we do not provide comfort care at the end of the line. We have lots of people who live with us for 8, 10 years. And we help them live and we help them live. And we do that by loving them with good care.
I appreciate that. My comments, I see a lot of caring, and I hear what you're saying. But I'm saying as a national issue, statistically, you look at what we're doing, and we're not doing what we should be doing. And the focus is, I wish everybody had a director like you, because that's not always the focus. And that's what the literature is going on. So that's what I'm speaking from. Although anecdotally, I think I don't think anybody went into the health profession unless they wanted to care for individuals. And I applaud you for in the administrative end holding true to that and fostering that in your environment, because it is critical. So thank you for your comment.
There is a paper that was recently published in Annals Internal Medicine regarding advanced directive, and it was published by one of the ethics professors of GECs, and it says that advanced directive is honored in less than 50%, and basically the complexity of the situation at the end of the life is so high that it's hard to follow the advanced directive.
Absolutely. The biggest benefit, the research is born, the biggest benefit out of advanced directives are the conversations, not the actual document. So talking about it is the most important, but the actual directive itself often is changed or negated at end of life. Yeah, so that's a very good point. The most important piece is those conversations. You're absolutely right.
We'll take one more question.
Good question. Advanced directives. As a former home health nurse and hospice nurse, we were required whenever we went to a home to present advanced directives or information about that. Are physicians required to present that? And furthermore, is there an ICD-9 code for that so they can charge for that 5 minutes?
Is there?
Is there?
Is there? That's a good question.
Not that I know of. Which may be one of the reasons why the physicians don't.
Well, you get back to the revenue that we talked a little bit, that the revenue supports treatment and not some of the end-of-life issues.
And the second thing, I totally agree with you about problems in the nursing home, and I applaud this lady for being in a good nursing home, but unfortunately my experience has not been that, and it's not because of the lack of caring of the DONs or even the administrators. The problem is the restrictions on the RCFEs and on the SNFs We all know that if you're in a SNP that you have to have an order to sneeze and then another order from the doctor to be able to get the Kleenex and then another order to be able to use it. And consequently, I have seen some of my end-of-life patients die very terrible deaths in a nursing home because the doctor was not accessible to be able to give the order to increase the morphine to a Q1 or Q2H for a person who's dying of multiple pulmonary edemas, effusions, etc. And they literally choked to death on their own saliva in front of the family because we couldn't get an order to give more frequent meds.
And that's a good point that you can't regulate. We put in the regulations, I think, well intended to really try to assure quality, but you cannot regulate quality. The quality is in this room. The quality is with the type of director